Welcome back to The Short Coat, coming to you from the amazing and intense world of med school at the University of Iowa Carver College of Medicine. I'm Dave Etler, and we're talking today about a lot of things, but in part, we're talking today about how doctors get paid. There are many ways that patients have paid for their health care, like with chickens and fee-for-service and value-based payments and concierge subscriptions. They're all trying to answer the same riddle: who pays, how much, and what happens when costs exceed expectations for either docs or patients. The business of healthcare has deep effects on who and how patients access healthcare, and we're joined by my co-hosts to talk about that. First up, it's MD PhD student Riley Behan-Bush.
Hi, everyone.
M2 Zach Grissom is here.
Hi.
M3 Alex Nigg returns to the mic.
Hello.
M4 Jeff Goddard joins us via the internet.
Happy to be here.
And if you thought that was all short coats, you'd better sit down. Sit down. Because we're also joined by Dr. Nathan Flacker, an attending physician with ChenMed, a primary care organization that caters to moderate to low-income seniors with what's called the capitated payment model. ChenMed has locations throughout the eastern U.S. Welcome to the show, Dr. Flacker.
Thank you for inviting me. I appreciate being here. I have a long coat somewhere, but I don't think I've worn it in a little while.
Yeah, that's all right. I feel like only in academic medicine do we wear the long coat. I don't know for sure. Why do I say we? I'm not a doctor.
Hey,
Just a podcaster.
You're a little bit.
I got my long
Your
coat.
legs can get cold, Dave. You can wear a long coat.
It's true. So yeah, I understand. We wanted to start off, Dr. Flacker. You started out in academic medicine, I think.
Yeah. So I went mostly reasonably traditional route, at least particularly at the time. College, med school, trying to figure out what I wanted to do. Probably like a lot of medical students, changed my career goal about 7 or 8 different times.
Sure.
How a lot of med students will find their calling in life, had a really wonderful physician who I decided I wanted to be like her when I grew up, because of the way she took care of her patients. If you're out there somewhere, Dr. Jewel Rhymes, shout out to you. And so I decided I wanted to go into geriatrics, went internal medicine primary care route to do that in Birmingham. And then in a non-traditional fashion, took a year off and backpacked around Asia for a year.
Yeah,
nice.
Rad.
Came
After
back
your residency?
between residency and fellowship. Yeah.
All right.
I took my fellowship program was kind enough to indulge me. Came back and did my geriatric medicine fellowship in the most academic of academic settings at Harvard. And so was deeply involved in research and those kind of things. And then at some point decided I didn't want to be a full-time researcher. I really loved taking care of patients. And at that point, my wife, who was from Georgia, and we had a lot of family, and we had met in college in Atlanta, told me I could get a job anywhere I wanted as long as it was in Atlanta.
Yeah,
I made
that's
a connection
awesome.
with program director there at Emory, and fortunately enough was able to come back. And my first job in Atlanta, I was completely unqualified for, which was to develop a geriatric medicine program at a public net safety hospital, Brady Health System here in Atlanta, which is a fantastic institution. And so I was at academic medicine for 16 years, in one role or another. And my last role was section chief for geriatrics there.
Yeah.
But I guess for me, part of my concern that we'll get into was I really love clinical care of patients, and the fee-for-service system was a real impediment to that. And I'll give you sort of a really brief story. For cheap date night, my wife and I volunteer usher at the Fox Theater in Atlanta, which is this beautiful historic theater. If you've ever been there, this has a point eventually if you hang in there with me. And so as you drive to the Fox Theater in Atlanta, on some of the most expensive real estate in the entire city at the time, they were building a $400 million proton beam facility. And I got nothing against, proton beam facilities. It's useful for some stuff. That's fine. So $400 million for proton beam facilities seemed to the healthcare institution powers that be to be a reasonable expense. And you can certainly make money with proton beam facility for sure.
What is it?
Yeah, I was thinking that sounded more like the loop.
Oh no! And it's cool. Like and by the way, it's cool. We like cool stuff.
Yeah,
So,
cool's good.
like if you're targeting certain spinal tumors, retinoblastoma, sometimes they use this for. I'm not an expert in radiation therapy.
Sure.
Prostate cancer. So you can like target the proton beam to like the thing you're trying to fry. This is the internist explanation of how a proton beam works, right? And then you don't have as wide a field of radiation causing damage. Like there's good stuff about it.
Yeah,
So,
good stuff.
fair enough.
Sounds good.
So $400 million for proton beam facility. And at the same time, I was having a wrestling match over whether a social worker for a geriatric medicine clinic was an affordable investment.
Okay.
Because you get paid for doing proton beam facilities and you don't get paid for social workers. So from a business point of view, sure, it made sense, but it's hard to have a geriatric medicine clinic doing good work without access to a social worker. And so there's a lot of those little things that are incentivized in fee for service. And so I had the opportunity, fortunately, it was a bit of a friend of a friend of a friend. A friend of mine had already joined the company, and I had another, like the guy I used to work for in Atlanta was in a golf foursome with somebody from ChenMed at one point and asked if they knew anybody in Atlanta. I was like that kind of deal, but it was a great opportunity to come and be in a completely different financial model, which we'll get into, which is the value-based care model, which pays you for, or at least you make your money if your patients are healthier. And that seemed to be a pretty good alignment for me. And so I made the jump and been here 8.5 years.
Do you have to do a fellowship in gerontology to take care of, or in geriatrics to take care of elderly people? I feel like most internal medicine doctors take care of geriatric patients without a fellowship.
It's a great question because if you felt like that you need to be geriatric medicine certified to take care of seniors, then we're stuck because we don't have enough geriatricians anyway. So from a practical point of view, it's an impractical approach. Also, many internists, family medicine, internal medicine docs take care of seniors. But just because you take care of an older person doesn't mean that you're doing geriatric medicine, because it's about the approach. It's about understanding how multiple coexisting comorbidities impact with each other. It's about understanding and assessing the functional capacity of the person, about what matters most to them, about how medications affect them differently. So can an internal medicine, family medicine trained doc take great care of older people? Absolutely. One of the key roles for geriatricians is to work with healthcare systems or healthcare institutions, or in my case, a healthcare practice, and trying to design the practice in a way that if you're not geriatric medicine certified, you're still doing geriatric medicine. That is, the systems are set up to do the right thing and make doing the right thing easy, as opposed to making doing the right thing harder. So, for example, care of seniors can become super complicated, but you can set up the system that helps simplify their complex care in a way that is both helpful to you as the care provider and, again, super helpful to them from a patient point of view in terms of understanding and being able to manage their healthcare.
So the difference is the system is set up specifically for this population, whereas other systems are set up to cover broad populations, and so maybe don't cater very well to the needs of this group. That's fair. Yeah, I would agree with that.
Okay. It sounds almost like how you're not going to have someone who did an infectious disease fellowship do every single communicable disease patient, but they're still there to be a sounding board or to be like arbiters of antibiotic use and stuff.
Yeah, right. So if you want to set up your system so that you're not overusing antibiotics, there are ways that you can embed your system in it. Infectious disease specialist would be a great person to help advise you how to do that and help set those systems up and monitor them.
And I have a feeling you'll touch on this, but when you talk system, are you talking the actual like providing of healthcare? Are you also talking about long-term care facilities, the family members or others who may be caretakers for those individuals? How much of the how broad is the system that you're addressing here?
It's really, really broad. So everything you've described there is a yes as an answer to that. And so where you end up professionally will determine sort of the scope of your ability to impact, whether it's your clinic, your hospital, in our case, a large outpatient practice. You can certainly do it from a public health perspective. But the healthcare system is kind of everybody. What is it like? I don't know, 15, 20% of health outcomes are what doctors do and in your office. So most of it's not even what's happening in front of you. And that other 80% is still part of the system.
Do you feel like, again, this feels a little bit of a tangent, but I think relevant to the conversation. We have this conversation, I think, a few times in medical school where, like you said, 20% of what affects the health of the patient or the health outcomes of the patient is something that the doctor has direct impact on, right? Whether that's the medications or the, whatever procedures and stuff. And the other 80% is outside of the clinic, outside of the hospital, outside of the healthcare system. How much of responsibility do you feel like we as providers have for that other 80%? Should we be beating ourselves up for what's happening in housing and the schooling and all this stuff? Do we abdicate complete responsibility and say that's somebody else's fault responsibility? How do you think about that?
So some of that depends, obviously, on your personal philosophy, but which I'll get into mine in a minute. Since we were talking about financial setup, so under fee for service, you get paid for doing things to patients, right? And those encounters. And so all that other 80%, you might feel bad about. You might even feel bad enough about it that you'd like to politically advocate for it, but it doesn't really impact you. And so, a non-compliant patient is often seen as like, that's the patient's fault. Like, why don't you listen to my really good, I went to school for all these years. I'm really smart. Why don't you listen to the stuff I'm telling you that will be helpful to you? Oh, they're not compliant. And then it kind of ends there. When you take a capitated value-based approach, all that stuff becomes, in many sense, your problem because you're globally responsible for their health outcomes. And while we have not gotten into building housing, though that'd be super awesome. It then becomes your responsibility, our responsibility for our organization, to try and dig deeper into what the causes of that non-compliance are. It is on us to build, like if a patient doesn't want to take a flu vaccine, don't stop it. Oh, well, okay, you don't want to take a flu vaccine. It's a why. It's what are the barriers to taking the flu vaccine. You have to dig deeper to understand what that is and also try harder to have a trusting relationship with our patient because our trust is the key to making everything happen. And so if I just rush them off as a non-compliant patient, I've kind of given up at that point, but they're still going to have their bad health outcome. And so I do think that the way you structure the financial system of healthcare then translates into the level of responsibility that the healthcare system feels for that other 80%. Right? And I think a lot of us personally feel responsible for that other 80%, but I wouldn't say, there's a difference between beating yourself up. Like I try not to lose sleep at night most nights over it, but I certainly advocate for improvement in a lot of those areas.
It's so interesting.
Go ahead.
Sorry, Jeff. The way you're describing, what the ideal encounter is with like digging deeper into the reasons and like trying to further explore why non-compliance is happening. Because as you're saying that seems like something that should just be like the bare minimum. Like that seems like what should happen with primary care providers, and it's it's hard because obviously that's not what is happening, and that's why we have something like ChenMed where these conversations are able to take place. But I guess it's just interesting because I think this is what should be happening everywhere, but we're not able to do that.
And again, it's the way that you set up the finances. I'm not trying to be too much of money because it's not all about money, but the way that your money flows and is structured determines a lot of stuff, even by really well-meaning people. I know people that run hospital system. They're like, most of them really do care about patients and patient outcomes. But when you're in a RV, relative value unit, based system, the point is to generate RVUs. Well, financial, but it's not to generate health, it's to generate RVUs. And there may be some relationship between RVUs and health, sort of, kind of. But in your typical outpatient practice, family medicine, internal medicine practice, you have panel size. I don't know if you have panel size. So panel size is how many patients are you as an individual provider responsible for? Have your name attached to them as their doctor, right? Typical is 1,500, 2,000, some I've heard higher than that. And so, if you've got 2,000 patients, how personalized can you get with them? How often can you see them? I'll give you, here's a basic example. When I talk to people who are thinking about joining us, I will almost always ask them this question. So you've got, say your patient is a 70-year-old female in really good health, right? She's got no diabetes. She's got low high blood pressure. The diabetes is well controlled on metformin. The blood pressure is well controlled on hydrochlorothiazide. She's functional. She's happy. She's doing great. When are you going to see her back? Well, so in a typical fee-for-service system, you'd say, wow, she's doing pretty good. I'll see her back and I usually get a range of 4 to 6 months. Okay, so 4 to 6 months. Your average patient encounter time in a lot of practices is, if you're lucky, 15 minutes for a follow-up. Might be less, might be a little more if you're super lucky. So you're seeing somebody for 45 minutes for an entire year. And you have all this preventive health stuff, which is all important. You got to cover, and you got to check off all the boxes for your quality metrics. How much time do you have left to really talk to people about healthy lifestyle and diet and exercise? Whereas in the way that we do value-based care, you do value-based care in a lot of ways. We have a high-intensity primary care model. So that lady that would normally be seen in 4 months or in 6 months, we would see her back in a month. That's our standard. It's a monthly visit, monthly 20-minute visit with your PCP. Now, in order to pull that off, you can't have a panel size of 2,000 people. But you can pull it off if you got a target panel size of about 400 to 450, which is our target panel size. And that's driven both because we care about patients, but you can't do a high-intensity primary care model with thousands of patients. It's why you see, and at some point, if you haven't, have somebody come talk to you about direct primary care. People do concierge models. What they're trying to do is get out of that trap of just having to just see lots and lots of patients to generate RVUs and find some other way to be able to have the time to do what you're talking about and really be impactful in terms of lifestyle changes. We're just doing it in a setting. We've already gotten to this. As part of our company's mission, we purposefully put our clinics in historically underserved neighborhoods. So we're trying to, as best possible, figure out a way to deliver concierge style care to people who would not normally be able to afford concierge medicine.
I really appreciate that last part, because I think that as I've seen concierge medicine come into the zeitgeist in the last few years, I think one of my main critiques of it has been that in order to get concierge medicine, you have to have enough money to afford concierge medicine. So I'd be curious to hear a little bit more about how, not just placing the clinics in the right areas, but how do you ensure that the population you're interested in isn't just those who are have expendable income and are able to afford it?
Yeah. So part of it is where and I'm not the person who picks where our clinics go, but I can tell you when I go around to our clinics, It's, whatever kind of desert you want to define, a food desert, or that's where our clinics are. And so, people who have a lot of money aren't probably driving to a lot of the neighborhoods where our clinics are anyway to get their healthcare. So one is just geographically where we place it. Number two is Medicare Advantage. Medicare itself as an organization, and Medicare Part C and Medicare Advantage are synonyms. Traditional Medicare is fee-for-service Medicare, and the Medicare Advantage is this Medicare Part C capitated system. And the flow-through is basically that the government pays an insurance company, and we're not an insurance company. I don't want to be an insurance company. The government pays an insurance company a fixed amount of money on a per member per month basis. And then the insurance company in a Medicare Advantage contracts with the provider group, that would be us. They take whatever their 15, 20%, do insurance company stuff with it, send us the rest, and then we're globally responsible. So Medicare Advantage, in terms of the number of people in Medicare who are doing Medicare Advantage as their insurance, has increased steadily over the years. I gave a talk back in 2004 about Medicare to a group of residents. And as I was talking about Medicare Part A, Part B, I got to Part C and I was like, you don't have to worry about Part C. Right? There's nothing happening there. That was my entire discussion of Medicare Part C. As of 2003, more than half of Medicare enrollees are now involved in a risk, what's called a risk contract by Medicare. And Medicare is explicitly stated, and I don't think it matters what political party is in control, they've explicitly stated that by 2030, they want pretty much everybody in a value arrangement, because from a government point of view, you can actually budget for that. Like you can't budget for fee for service because it's just the bills come in and you pay them. And so I've lost my train of thought. You might want to keep that in. You might want to edit that out. I started answering a question and I went somewhere else.
That's all right. It happens.
The question?
It happens to us regularly. I felt like you did.
Yeah.
I think you answered the question, and you've given so much more information, because one of the things I've, again, thought about a lot recently, and again, I've had lots of a side quest of a PhD to think about this, but I think a lot about like, how do I get paid? Like, how does any of this work someday? And I think that is so interesting. And I don't know, from your guys' perspectives, being entrenched in medicine right now, are medical schools doing a good job of talking about this? Because I think this conversation needs to be happening sooner, because everything you're saying about the clinic model sounds super awesome. And I think it's important to get exposure to these different types of models earlier on.
We'll continue our chat with Dr. Nathan Flacker of ChenMed in the next episode when we get into the nitty-gritty of the different payment models, including capitated payment and how it affects patients and the practice of medicine. In the meantime, Shortcoats, if you have something you want to say about today's show, about something you want to hear someday, question you have, go to theshortcoat.com/tell us and send us a message. Otherwise, that's our show. Until next time, I'm Dave Etler saying don't let the bastards get you down. Say bye, everyone.
Bye.